welcome to the Lane County Board of Commissioners meeting for November 4, Election Day. Oh, yeah, 5th. Sorry about that. November 5, Election Day in our sister state of Washington. A lot of county commissioner elections going on up there today.
Guy Fawkes Day in England.
Yes, exactly. We've got several adjustments to our agenda today. The first is item 12B, which is on page 4 of your printed agenda. That's the lien forgiveness matter. That's been pulled from today's calendar and will be on next week's agenda. That's being pulled at the request of Public Works. I also want to mention there are 3 executive sessions today, and they'll be shoehorned into the agenda as we can fit them in. We want to set up our any emergency business today, and I don't believe there is any. Mr. Mokrai, no. So we can move on to item number 3, which is our public comments. We've set this up to take up such time between now and 9:30, and our vice chair will turn the time on. So when you come up to the microphone, you'll get, please introduce yourself and tell us where your name and where you live, and our vice chair will start the timer at 3 minutes, and at 2 minutes and 30 seconds, i.e. with 30 seconds to go, the yellow light will come on. And then is there a buzzer this time?
It beeps now, I think.
I think it beeps now to tell you that the red light and the beep will tell you that you need to conclude your comments. So first up is Andrew Frost, followed by Dave Piccioni, and followed by Wayne Martin. Welcome, Mr. Frost.
All right there. Good morning, everyone. I've seen a few of your faces before. I came 3 years ago making what I thought was a pretty valid complaint. Oregon law says that you have 31 days as a loan shark company or payday loan company. You have 31 days to pay it in. Yet Lane County only gives people 21 days. Now, I haven't seen anyone's made anything to try and rectify this problem. It's not hard to write a law that says your tax assessor has to give 31 days. Other counties decide to give it. They don't look at the minimum and say we will go for the minimum possible. They say we will do the best for our county. Now, this county so far has said, don't give a flying one. We don't care if some poor people get screwed out of this because the bill came with a 21-day notice. I found out because I was away for a month, prepaid all my bills before I went away, came back, went to the tax assessor 2 days late, tried to get him to say, all right, that's fair enough, you don't have to pay the extra. He said no. I then said I want to go up and speak to Sid Lykin. So I left his office, went up to speak to Sid Lykin, was standing there talking to Beanie when a police officer told me to leave the building for making a disturbance because I had said that I was looking for representation over taxation. That part has been ignored by the commissioners that were on the panel for the last 3 years, who said it doesn't matter that our tax collector can go grab a policeman to force someone out of his democratic right to speak to his representative over an issue that I shouldn't think everyone could understand is a fair point. You normally get 31 days to pay a bill. If the state's going to require loan shark companies and other payday loan companies to do that, why can it not behave the same way? And when I say the state, I mean the county in this case. I think that's all I have to say.
Thank you. So we have Dave Piccioni, followed by Wayne Martin. If you could give us your name, where you live, we'll start the timer for 3 minutes.
Thanks. My name's Dave Piccioni, and I live in Eugene. I was told that one of the topics that was important today to talk about is health care. And just like that, this idea came to my head. This is our environment, and when a woman is pregnant, she's got her baby in her womb. That is the baby's environment. It's this ball where it's in, and little nutrients and antibodies and, just general things feed the baby. But you gotta keep its environment. You don't want a woman smoking, shooting up heroin, whatever. Yeah, you can do that after the baby's born, but. Yeah, so our environment, in the same way, we are surrounded by Mother Earth, or whatever you want to call it. It's this is our environment. It's a lot bigger, a lot more varieties of perceptions than a baby would have inside the intrauterine space. There was a doctor named Stanislav Grof who he did a lot of research with and treated people that had very severe psychological problems with LSD. He was Czech. And he found that depending on what kind of birth the baby had, whether it was very hard and it was pressing against it, there are people that have different characteristics, and you qualify like 4 different ones, but there's more. How a person, like he talked about Hitler and all these people, what kind of birth they would have. And birth turns out to be very important, because if we have a trauma at birth or before birth or even after birth, when we are establishing a new relationship with our mother, we're separate individuals at that point. That shapes the life that you're going to have when you continue on as a growing person, and so it's very important to have a good environment for us, just like it is for babies. Thank you.
Thank you very much. Thanks for your public comment. Okay, Wayne Martin, if you could come up. And I know you know the rules, so go ahead.
Good morning. I come with no real speech, but actually desiring whether or not, desiring if you could give me a couple of answers to some questions. And I don't know the answers to, so these are not rhetorical. One is, how is the progress coming along for the use of the Lane County Fairgrounds for the 3 proposed tiny homes? And would you recommend a good reason for me to attend their monthly meeting this Thursday, just to find out something, or even whether or not I can make a small statement? 2, help me with whether or not there's been any progress made in the search for the systems implementation manager. And 3, I just want to make a statement of thanks for your capacity to support Nightingale Health Sanctuary, Nightingale hosted shelters. We have had a really dramatically powerful fall. We had our first major fundraiser, and we took in about $16,000. We're not used to that. And I wanted you to feel the strength of what you have been giving us permission to do. Oh, one last thing. Can you answer this? Is there a way in which you can let me know what the codes are for the county as far as overnight sleeping is concerned? Because I'm at a loss, if you could help me with that. Thank you.
Hey, thank you very much. Since is there anyone present that has not been given an opportunity to give public comment that I haven't seen on the sign-up sheet? Okay, so thank you, everyone, for your public comments. Since we are running ahead, perhaps we could go to item number 4, Commissioner response to public comments and other issues from commissioners. Do any commissioners wish to be recognized? Okay. You will. Okay, Commissioner Burney.
Sorry. As one of my constituents, Mr. Frost has communicated with me quite a bit about his frustration, and on the surface of it, I don't have an answer, but we ought to get an answer. And I've seen through, you know, I can appreciate, sir, how frustrated you get and how sometimes that can become consuming, and sometimes people hear that rather than the substance of the request. So I think it makes sense to see if our county could make the change in the dates, the number of days between receiving property tax bill and it's due. I don't see that as a major thing. I'm being told it's statutory. Is that correct? Anyway, so I just wanted to say that. But if it is statutory, and that's another thing. But we'll find out. We will find out, sir. And that's all I really wanted to say, other than I wanted to share that in 1970, in terms of childbirth and those first experiences, it was my pleasure in 1976 to spend 7 months on the island of Bali in Indonesia and living in a remote compound. And it was fascinating to observe that in the first 2 years of a child's life in that culture, it did not know one moment without human touch, that someone was carrying or holding it or its hand, and the happiness and peacefulness and sort of the gentleness of that culture. I don't know if there's a connection, but I just wanted to share that given your remarks. Yeah. Thank you, Mr. Chair.
Okay, Commissioner Farr.
Thank you. Wayne, thanks for your testimony today, as always. And I'll just forward a question to Mr. Mokrahajski. Perhaps during your administrator's update, you can talk about the 3 Conestogas and about the SIM search. Just give whatever's happening currently on both of those. Wayne, I'll be there Thursday morning. If you show up at the Fair Board meeting, I'll say hello. All right. And just a reminder that today is, in fact, the day the gunpowder plot was discovered in England. So, thank you.
Okay, any other commissioners want to make any remonstrance or comments? I'll just do mine. I want to thank Mr. Frost for coming today. As I mentioned him, I looked into this, and it is a state law. I think if he's raising a new issue of whether this is a minimum, I think that's something worth looking into. I believe the last time he was here and I had some conversation with him that I learned from from our assessor, Mr. Coles, that we were in compliance with state law. So could be that we could reopen that issue. I don't see it as quite as imperative as he does, but I'm certainly open to finding out the pros and cons of the change from 21 to 30 days or 31 days, as he stated. The other thing I'll mention is that, yes, Mr. Martin, I think it'd be good to go to the Fair Board meeting. What they're mainly going to be talking about, from what I understand, is the work session that we just had with them last week about a permanent supportive housing project, and that is very much in flux. We don't know if that's going to happen or not. So it'll be interesting to learn more about that. But I don't know what that has to do with the current proposal for the Conestogas. So your advocacy would be most appreciated by me. Thanks for the thanks. I didn't play any role in your success, but I'm really glad to hear about it, because that's a lot of money to a group as small as yours, and I appreciate you pointing that out. And last but not least, I agree with Commissioner Farr. We're going to probably get an update from Mr. Mokrajewski on the systems implementation manager, as well as this fairgrounds issue that we learned about a little bit last week, and the relationship between the Lane County Health and Human Services proposal to use some of the land on the fairgrounds property to obtain a state funding for a low income or affordable housing or some other type of permanent supported housing at the fairgrounds. So thanks for your advocacy. Pardon me? Yeah, okay. Thanks for letting me know. And so the other thing I was going to mention is that, and Mr. Martin, you're here, and other advocates for housing and housing as a right or housing as something we should be doing a better job with. And this is a bit of a nuance. I think a lot of times we're putting the focus on housing in terms of policy, the city, county, government. And really, with the numbers, the over 2,000 people that are without any housing, they're also without any shelter. It's not true, okay. So there's a lot of people who I see when I drive to work who are seemingly unhoused and unsheltered. They're outside, and they may be sheltered in the sense that they have coats on, or they have hats on, or they have a tarp over them, but I don't think it rises to my level of shelter, okay? So we have thousands of people, okay, in this condition. We have a public who is, I think, generally warm-hearted, that generally thinks this is a bad idea. And I think one of the problems is that our focus is on doing something about this in a longer-term fashion. And meanwhile, we have these unsheltered people. And I personally have been impressed with some of the testimony we've gotten, public comment, where, hey, if people have a place, they have a place to lock up their stuff, that's a start towards maybe the government's HUD's version of housing. But if we can accommodate those two things at a minimal cost per person, that would be a big help to a lot of my constituents who not only are unsheltered, the ones I'm talking about, the thousands or whatever, but also all the people in the community like me that wonder, what can we do a better job? How can we do a better job of helping these people? So thank you for all of what you do. And I'd be happy to be corrected on the number of people that are housed, unhoused, sheltered, super housed, double housed, however we measure the different types. I know there's so many condominiums in Miami that are unoccupied that they're thinking of having an unoccupied housing tax, you know, because there's some people that have more than one house. So anyway, thank you so much. And Commissioner Buck, you're recognized.
I just wanted to say something about voting, because today is the day to vote. And although I'm wearing a sticker that I voted, there's not necessarily anything in my particular district for me to vote on, but I do represent many communities that do have something on the ballot, and want to thank everybody who's getting out there to vote. I know it feels like there's not much on there, but it's so important that people do take the moment to get those ballots in today. Thank you.
Commissioner.
Thank you. So just real quick, the homeless point in time count was 2,165 people that were considered homeless according to HUD's definition. Of that, 426 individuals were in a emergency shelter. Another 106 were in transitional housing. And then there was 1,633 that were considered without shelter according to HUD's definition, which includes anyone that's in our MASH tents out there in our dawn to dawn and dusk to dawn programs, because they don't consider that sheltered. You have to have a roof over your head to be sheltered. Our, Egan warming centers are not considered shelter. So that, when you have to, by the HUD's definition, so yes, there's over 2,000 people homeless in Lane County, but we don't have 2,000 people that are unsheltered. And then even, are you talking about HUD's definition of shelter? Because I think a lot of what you're talking about, Chair, is something that HUD would not consider shelter. They don't consider Dawn to Dawn a sheltered program. They don't consider our car camping program shelter. They don't consider the Conestogas shelter in their definition. They would all be listed as part of that 1,633 people that are unsheltered. I also just want to note for Mr. Frost that the 21 days is statutory, running between the last day that the state allows tax bills to be mailed by the counties that are in charge, the assessors that are in charge of mailing them. Part of that is you start counting backwards to the last tax cycle, to certifying tax rolls and everything else that goes on. We consistently have had to ask the state for a waiver to get our CAFA grant because we understaff our assessment and taxation department. So they are always running up to the very last day to certify, running up against the last days to mail. So if we're going to talk about trying to go earlier than 21 days, then we better start talking about how we're going to staff them. Secondary to that is that deadline is just to get your 3% discount. Your actual taxes aren't due, and it's only 1/3 aren't due until February. So you're not really late. You just don't get your 3% discount for fully paying your taxes by a certain date. Now, so that's kind of, what's at stake here is either we have to restaff our assessment department. I think if we wanted to have a work session, maybe have Assessor Coles come and talk about how difficult it is to get 170-some thousand tax accounts ready to be mailed every year. We can talk about that, but we consistently have to request a waiver from the state to get back our own money on as far as our CAFA grant goes, because we are understaffing according to statute in some ways. And that's been consistent since we lost our SRS money back with our 2011-12 budget. We've had to consistently ask for that waiver. So just a little bit of background on why there's only 21 days there.
Okay. Commissioner Buck.
I just wanted to add a thought. When we're talking about those that are unsheltered and the point-in-time count earlier in the year, and we're looking at the numbers that were provided, I think we're kidding ourselves if we think we've caught everybody in that count. It's not as accurate as we hope it would be. And it's grown, but I still think it's a fraction of everybody that's really out there. What that fraction is, nobody really knows. So I do feel personally that it is much larger than what it looks like at one point in time.
Okay, any other commissioners on our second round? Commissioner.
Sure. We've been working on issues surrounding poverty and homelessness for as long as I can remember, and we do make progress and we do slide back. One thing that we can look at with the homeless point in time count, while it is inaccurate, it is understated, how does it trend from year to year? And this year, the last couple of years, it is trending up. We know that. As consistent throughout West Coast cities, it is trending up along the entire West Coast. So it's something that is happening that is actually beyond local control, perhaps, in some cases. But locally, we can continue our efforts, Mr. Martin, and we'll continue our work and do the things that we have been doing and try to add to it. If you've been watching our homeless efforts for a lot of years, you know where we've succeeded, you know where we've failed, you know where we were 7 years ago compared to where we are today. So I don't have to talk about that. I don't have to make anything up or try to manufacture numbers for you. The fact is we are trending up, and that is a West Coast phenomenon.
Okay. Any other comments? Mr. Mokrice, you wanted to be recognized.
I just thought, since Mr. Martin was here, I'd give a couple quick updates. The Fairgrounds, Conestogas, we have a work session, a discussion will come to the board on December 10th. It's my understanding, based on the report we heard last week from Homes for Good and our human services, that There's currently neighborhood outreach that's happening, and so there's discussions with the neighbors to inform them about the planned temporary use for those Conestoga huts, and then a discussion again planned on December 10th for the board to talk about that. In terms of the management level position, we are searching for that position. We've sort of restructured it and made it a county position that we're going to hire for, and we're working with a recruitment firm to do that. So that is open and actively being recruited. And then on the code for overnight sleeping, I'll ask Ms. Gaffney if maybe we can follow up with Mr. Martin. I'm not going to put you on the spot and ask you what the code is, but we will follow up with Mr. Martin and get a response to that. I'll have more under my announcements, but I just thought I'd provide that now.
Thank you, that's very helpful. Okay, so why don't we take up the consent calendar before our 9:30 item. Are there any items on the consent calendar that any commissioner wants to pull for a separate discussion? Okay, seeing none, I'll entertain a motion for approval of the consent calendar, item 6.
So moved.
Is there a second?
Second?
Okay, moved by Commissioner Buck, seconded by Commissioner Burney to approve the consent calendar as presented. All in favor, please say aye.
Aye.
Opposed, say no. Motion carries unanimously, all commissioners voting in the affirmative, and all orders on the consent calendar are approved. So at this time, I'll call up our next agenda item and ask our folks from the Board of Health to come forward, and I'll recess the Lane County Board of Commissioners, and I will reconvene or convene the Lane County Board of Health this Tuesday, November 5, 2019. Lane County Board of Health is statutorily created by Oregon statute, and the 5 members of the Board of Health are here. We have 2 items on for the Board of Health, and the first is the semi-annual Board of Health report, item 2A, with Karen Gaffney, Director and Public Health Administrator, Dr. Patrick Ludke, Public Health Officer, Dr. Jocelyn Warren, Lane County Public Health Manager. We set this up for a 40-minute presentation. So which one of you is going to manage that 40-minute time? Very good. Dr. Warren was nominated by Dr. Ludke. So welcome, Dr. Warren, and please proceed.
Thank you for having us today. We appreciate the opportunity to talk to you about the state of the county and various health domains. Today we are going to be talking about sexually transmitted infections, but before we get there, we thought we'd give an update on the measles case we have in Lane County, and Dr. Ludke will provide that.
Happy to do so. Mr. Chair and Commissioners, thank you for the opportunity as well. So a single measles case doesn't mean that we only have one conversation, and certainly this board knows that. We have 2 main groups of people that we liaison with when we have a disease outbreak, those persons with the infection and those persons at risk for it. So in the measles world, we call people who have been exposed a PUM, a person under monitoring, and that's not our term, it's a Center for Disease Control term, but that's what you call them. And we also have the group of people who are not exposed but are concerned, and we have potential contacts for them, and we're talking about over 50 people in the latter group, persons who were wondering if their visit to the Creswell Bakery or one of those sites potentially exposed them, and those persons who actually visited one of the 4 sites and who were potentially exposed and are a person under monitoring. So in the former group, 50+ people, in the latter group, 10 people, and the persons who are under monitoring, we want to make sure that they don't become sick. So we do a fever watch. We have routine conversations and calls with them, check to see if they have a fever, if they develop a rash that's consistent with measles. So the long story of all that is we get really jazzed about a single case of measles, a single case of mumps, because we get to liaison with the community. The dates of all of this, as you probably know from the newspaper and from our reports as well, the initial exposure was on a flight on October 12th. And the patient in Lane County became sick with a rash on October 25th. And if you time out the typical incubation period for this particular virus, if we don't get any more cases by November 13th, we breathe a pretty big sigh of relief. But then we typically have to wait a total of 2 incubation periods, which is 21 days plus 21 days, or 42, before we breathe that huge sigh of relief that our community is out of the woods for now. So November 13th is the first date where we hope we don't get any new cases, and we'll feel pretty good about not getting any more. But then 21 days later will be when we really say, all right, our community is safe. So I'll stop with that for measles.
Thank you. Would you like to have any questions about the measles case that you'd like to?
Why don't we finish your total presentation before we invite the commentary and questions?
Okay, so we are going to be talking about sexually transmitted infections today. We'll start with some background on STIs, information about what those reportable STIs are for the County Public Health Department. We'll talk about what we're currently doing in public health, what we're planning to do for the next biennium, and then we'll have time for questions, feedback, and comments. So to begin, Dr. Lucky will start with the background.
Happy to do so. And the background, of course, includes a poem. So I would request permission to approach the bench.
It wouldn't be the Board of Health otherwise.
Wow.
I'm surprised we don't have a book of poetry waiting for us.
So in many ways, our view of sexually transmitted infections involves some age-old questions, questions about culture, questions about human behavior, and I think this poem is fitting to discuss each of those areas. Plus, it's very short, so it fits well there, too. So W.S. Merwin, a Pulitzer Prize-winning poet, he sadly recently passed away, but he is one of my favorite poets for sort of the sensual, the sensuous in our English language. And he did a lot of translation of ancient Far East writers. This is one of the writers in particular that he did some translation on. Tiong Po is the poet who wrote 1,000 years ago, roughly. And this is a poem written to him after having translated a good number of his works. Almost 1,000 years later, I am asking the same questions you did. The ones you kept finding yourself returning to as though nothing had changed except the tone of their echo growing deeper. And what you knew of the coming of age before you had grown old, I do not know any more now than you did then about what you were asking. As I sit at night above the hushed valley, thinking of you on your river, that one bright sheet of moonlight in the dream of waterbirds, and I hear the silence after your questions. How old are the questions tonight? So I think that encapsulates some of the way we look at these various types of infections, sexually transmitted infections and others, human behavior, age-old questions, culture, the impact of culture on human behavior. So with that as a preamble, I'm going to talk briefly about STDs in general, and then we'll go into a few specifics, predominantly the bacterial sexually transmitted infections. So you can see on the slide here that we'll have 20 million sexually transmitted infections in this country this year. Roughly half of them will be the human papillomavirus, which is the virus that causes genital warts. It's not a reportable disease. We don't track it. There's way too many of them. And many people, around 95% actually, eventually get immunity to them. And over the course of a few years, they beat it themselves. A small number of people don't beat it, and they can go on to have risks for cancer and such, but we don't track that. But around half of that 20 million number is genital wart infections. That being said, there are many that are not diagnosed. There are many that, sadly, people don't present to a primary care provider, an obstetric provider, and no testing is done until there are downstream effects. And we'll talk a bit about, especially chlamydia, some of the downstream effects from these types of infections. The final bullet on this slide is that STIs are preventable. And sometimes it's lost in the conversation, whether it's a clinical conversation or a community conversation, that these are preventable infections, just like many other infections are preventable. And we have some evidence-based strategies to address them. We'll talk about a few of those today, and others that are gaining evidence that the community of public health is looking broadly at, including leveraging social media and other new technologies. Next slide, please. You likely heard from some of the media fanfare that the Center for Disease Control released its big report just a couple months ago about 2018, and sadly it was a record year in the STI universe in our country. record number of cases, 5 years in a row where the numbers have increased significantly. And for the big three bacterial sexually transmitted infections, it was particularly onerous and notable. Chlamydia cases were up almost 20% across the country. Gonorrhea, you can see, dozens of percentage increases, which is, a sad number, and then syphilis, about 70% elevation. And we participated in each of those to variable amounts, and we'll get into the details in a moment. Next slide, please. So for chlamydia, I think you've heard me say before, when we talk about sexually transmitted infections in Lane County, for chlamydia, we talk about thousands of cases. For gonorrhea, we talk about hundreds. And for syphilis, we talk about dozens. So chlamydia is really the big one in terms of numbers. It's the most reportable infection that we have in Lane County. And there are roughly 70 mandatorily reportable conditions to public health, and this is the number one for reporting. And the numbers have been increasing for some time, and then they kind of stabilized 2018 over 2017, and you'll see the graph in a moment on the next slide. But chlamydia is really, it's a smoldering type of infection. Many people have it and they're asymptomatic, as opposed to an infection like gonorrhea, where pretty quickly, especially in men, it hurts to pee and and you go see a doc, and a little longer of a bit of smoldering incubation period in women. Chlamydia, it just smolders and smolders and smolders, and you can have a chronic infection for a long period of time. Roughly half of all infertility cases in this country are caused by chronic chlamydia infections in women. And it scars the fallopian tubes, and it results in infertility later in life. So that alone tells you this is something we need to know about. But it also causes chronic pelvic pain, and sometimes the infection can cause really severe disease where it marches up into the abdomen and causes what's called pelvic inflammatory disease. And people are hospitalized for that condition. And occasionally people die from it, but pretty rarely. So you can see our numbers, the two columns, Lane County, United States. We were down just a tad, roughly leveled off, not statistically significant, about the same as 2017, and a roughly 3% increase in the United States. And I think at this point, sort of early on in the presentation, it's really important to note that our disease surveillance systems are really the minimum number of cases that we know are out there. No surveillance system is perfect. We have these wonderful mathematical algorithms that gives us an idea. Are the true number of cases twice what are reported to us? 3 times, 5 times? For some of these STDs, it's 3 or 4 times. For chlamydia, it's probably about twice. But this is the minimum number of cases. So next slide for the graph, please. So you can see the trend over time, not a steep increase, but an increase, and it's an increase a little higher than the natural growth rate of our community. Over the last 5 years, our population grew about 6%, and chlamydia is up, about double that, 8 to 12% in that time frame. But a slow, progressive increase, and 2018 over 2017, again, roughly stable. Next slide, please. Gonorrhea is one of those that is not stable. It's jumped all over a little bit. And again, if you remember, when we talk about gonorrhea, we talk about hundreds of cases, so smaller number than chlamydia. It's the second most reportable condition to Lane County out of those roughly 70 reportable diseases that we track. Nationwide, and we're a little bit different in this community than nationwide. Nationwide, it's significantly in men, and a good number of the gonorrhea cases are in men who have sex with men. In our community, we're approaching 50% women, 50% men. There's roughly 8 counties in Oregon of our 36 counties that are that way. We don't fully understand why. We wish we knew. We're actively looking at it, trying to gather more demographic information, more sexual practice information, but we really don't understand why it is that we have a higher rate of females with gonorrhea than we do across the country. I think it's also interesting, or maybe important to note, that there have been huge changes in antibiotic resistance for this particular bacteria. Whereas syphilis, which we'll talk about next, is still sensitive to penicillin, and it has been since penicillin was found in 1928. Gonorrhea has progressively become resistant to huge classes of antibiotics. So back before penicillin, we had sulfonamide antibiotics. Very quickly, within about 5 years of use, gonorrhea became resistant to sulfonamides. Then we had penicillin into World War II, and within about 5 to 8 years became resistant to penicillin. Then we had a new class of drugs, tetracycline and minocycline, doxycycline, all the drugs in that particular group. And within about a decade, became resistant to all of the tetracycline derivatives. And then we tried fluoroquinolones, probably a common one you know is Cipro, fairly common drug we use for other infections, became resistant to Cipro. So now we're stuck using 2 drugs, kind of like tuberculosis, where we use 4 drugs to treat TB. For syphilis, we use 2 drugs to try to prevent future resistance. but really because it is an ongoing challenge that we only have one class of drugs that works really well, and that's cephalosporins. They're kind of like a super penicillin. So we are really nervous that there has been some reported resistance to this class of drugs in Southeast Asia. And sadly, like pandemic influenza, STDs don't stay in one particular place. They spread around the globe eventually. So we're nervous. So we do surveillance to make sure that our state is not seeing this resistance. But if we were to have resistance to this class of drugs, this particular sexually transmitted infection would become really hard to treat. And it would become much more expensive to treat. People would have to have an IV and get IV medications as opposed to taking a pill. It would be a real challenge. So we're watching that, and we're nervous about it. And again, in the two columns, you can see our gonorrhea numbers up significantly. And let's go to the next slide. You can see how gonorrhea has kind of gone up and down a little bit. But again, the main trajectory over the course of this decade has been up. And there was a time period early on, 2011 to 2014, we were up about 400%. But of course, we started at pretty low numbers, so statistics can kind of trick you a little bit when you start at low numbers. 2015, we mounted a pretty big campaign. You'll probably remember we were in the media, did a lot of interviews with newspaper and radio and television around the huge increase in STIs and did a lot of outreach with our clinical partners. We think we made a difference. In 2015, it dropped a bit. We can't prove that, but we think we did. One of the numbers that helped us get a sense that we may have made a difference is we asked the laboratories, there's 4 main clinical laboratories that serve our county. We asked, is there even more testing? There's a large increase in testing after our campaign with providers, which is good because we can't solve this issue until we diagnose it. So we had a big increase in the number of tests from the 4 main laboratories, and consequently we got more cases, and then we had an opportunity to address those cases, and in the following year we saw a pretty significant drop in positives. But it's continued its trajectory again, and we're pretty nervous about that. Let's move on to syphilis, if you would. So syphilis is, from a clinical standpoint, it's a fascinating infection, and I kind of hate to put those two words together, but in medicine, there's this old saying that if you know syphilis, you know all of medicine, because syphilis can infect every tissue in your body. It can cause heart attacks and strokes. It can cause brain disease. Al Capone died of neurosyphilis, famously. It's a nasty, nasty infection that can go anywhere, and it can present in a number of different ways, not just a genital sore. It also can cause congenital disease. And our community, our state, had gone decades without a single congenital syphilis case. And last year we had 12. And the challenge with congenital syphilis is, first of all, it's preventable, and it's really a lifelong sentence for the kid. But these children are often cognitively impaired, along with major birth defects, and they live a normal lifespan. So it's a real costly infection to society. You may have someone living to age 75, and they're a ward of the state for a preventable infection, which is a real challenge to us and a real concern to us. The numbers are not as high as they were in the 50s, 60s, and 70s. So historically, we're not where we were quite back then. But over the last 20 years, they're up much higher than they've been since the 1990s. You can see on the 2 columns again, we had a significant decrease from 17 to 18, but we're going to give you a pre-look at 2019 here in just a second. But across the country, the numbers are way up. And they're also up in Canada and in Mexico. The Mexico disease surveillance systems are not quite as good as sort of their neighbors to the north. The Canadian disease surveillance systems are very good, and Edmonton and Calgary and Vancouver, all these cities have huge increases in syphilis as well, just like us down in the lower states. Next slide. So the graph, you can see we've gone up quite a bit, and then last year we had a decrease. And we did a lot of work around syphilis with our clinical community, and not quite as much as we did with gonorrhea a few years back with the broader community. We think maybe we had some impact on decreasing those positives. And then if you go to the next slide, then you start to do an early look on 2019, and we've already passed, after 6 months of 2019, the total number of cases for 12 months of 2018. And that's a big concern for us, as you might imagine, as well. And this this particular population of persons with syphilis is spread across the decades. So one of our jobs in public health is to really torture our data. We torture our surveillance systems. Are people testing more or testing less? Are we fully understanding the age and demographics of who's getting these infections? Are we fully understanding the practices, whether it's a specific sexual practice or perhaps it's what we call a syndemic, where it's not just an epidemic, but it's two things happening at once, so drug use and unprotected sex. So we look at these things and torture our data a great deal. And go one more slide, if you would, please. So this is the first 9 months of the year, again, split across male, female, and total count. And the numbers are up quite high. And when the numbers get this high, and especially when you see a fair number of women, we're worried about congenital syphilis cases in our community. So we've been working with our obstetric gynecology providers saying, you know, it's out there. And the recommendation has recently been changed to test a pregnant woman twice during their pregnancy to 3 times. First trimester, second trimester, third trimester, to make sure we don't miss it. Because again, 75 years of lifespan and a significant birth defect and or cognitive impairment is a really expensive infection. So next slide, we'll shift to HIV briefly. This might be the good story where public health and the clinical community work. So we've had large increases in these bacterial infections, but our HIV numbers have been stable. We average typically somewhere around 8 to 12 new HIV infections per year. The last couple of years, it's been about 1 per month, 12 per year. And that number's been pretty stable. And again, the numbers are small, so if you get 2 new cases, your percentages increase significantly. But the reason we think that it's been stable is, first of all, we have the access to what we call ART, antiretroviral therapy. So we're a state that expanded Medicaid. Anyone who gets HIV who's not insured can get on Medicaid and get treated. And these medications are so good now. Maybe you've heard of U equals U, maybe you haven't. Undetectable equals untransmissible. We have HIV medications so good now that we can't detect any HIV virus in your body, and these people are not transmitting the virus even with unprotected sex. So U equals U. So we're lucky that our clinical community and public health is helping identify and then treat these people. So they may have unprotected sex and pass syphilis, gonorrhea, and chlamydia, but they're not passing HIV. Which is wonderful because, again, this is a very expensive infection and it's lifelong and we can't cure it. So the numbers are relatively stable. We had 12 cases last year, again, 1 per month. We wish it was 0 per month, but that's not where we're at. No big spikes, as I mentioned, again, because I think public health and the clinical community are working very well together to identify and treat these infections. And again, this, I think I mentioned it in one of our prior presentations, that there are communities that have another way of getting HIV, not just through unprotected sex, but through contaminated needles. And we have our share of persons injecting drugs in our community. And we have looked at other communities at serious risk for increases of HIV that can happen very quickly if, say, fentanyl or some other opiates come into their community. And back in 2015, 2016, you probably recall Scott County, Indiana, had a huge outbreak. It's a small county, only about an hour from Indianapolis, and they had 191 HIV cases in a county of only 24,000 people. So, you know, put that in perspective. We have 375,000 Lane County citizens, and we average 12 per year. They had 191. So if you just do quick math and look at what would happen to our community if we had an outbreak sort of like what happened in Scott County, we would have 3,000 cases of HIV in a year, which would bankrupt Medicaid. It's very, very expensive. So this is an area where, number one, we're very fortunate to have public health and the clinical community working well together, to have a needle exchange, preventing this other way of getting HIV through dirty needles. We're very lucky to have that program too. And again, we continue to watch it because HIV is such an expensive condition. We want to make sure those numbers don't change and the graph looks ominous next year. So I'm going to pass it over to Jocelyn now.
And I think maybe we have some technical difficulties now with our slides. Oh, wait a minute. There we go. We're back. Okay. So public health is working at a number of levels to help control the spread of STIs in our community. Our efforts are at the individual and partner level. We also work with the health system, and then finally at the community level. In terms of the individual efforts, we offer low barrier testing at the health department, and we are also including additional sites for testing, such as Looking Glass and Camp 99. Our nurses actually go out to those sites. We additionally provide treatment to anyone who needs it, regardless of ability to pay, of course, as Pat mentioned. Some of the really interesting work, I think, is done by our disease investigation and intervention specialist. She does the investigations, which means tracking down the partners of our patients through social media. She visits homes, she visits camps, sometimes the jail. It's a challenge sometimes to maintain confidentiality in those settings, so she's very careful about that. But we also have to make sure that the people who have been exposed to gonorrhea, HIV, and syphilis in our community know that and are able to get tested and treated if necessary. And why our staff are effective, I think. We had one syphilis patient say to a staff member that they were embarrassed when they got the information that they had been exposed. And they didn't want to deal with the information. They didn't want to deal with testing. They knew that something was wrong. But she said that with this staff person, with the nurse, she never felt judged. So she was able to get in. She was able to get tested. She was able to get treated. And she said that she thought the nurse saved her life by being able to get her in. I think that's a really important piece of what our staff do out in the field, too. We also work with the health system. So we have a couple of different coalitions. One is called the STI Prevention Coalition, and that is a provider coalition. It involves representatives from UO, from Kaiser, the CHC, LCC Health Center, Planned Parenthood, HIV Alliance. That provider group is working on standardizing services and making sure that everybody has the same messaging around STI prevention, testing, and treatment in our community. It's almost a little bit like a one-door policy, like everybody gets the same information no matter where they go in the community, and we know that it's up to the standard that we expect as well. So that's a really important group. We also have the Harm Reduction Coalition, and this really addresses the syndemic that we talk about between drug abuse, homelessness, high STI rates, and some behavioral health issues. A lot of these are common risk factors for the health outcomes that we're looking at. So this Harm Reduction Coalition is really involved in looking at the messaging around a lot of these issues, assuring that things like testing become normalized and not stigmatized. That's a lot of the work they do. The partners in that involve HIV Alliance again. They're one of our main partners. We also work with State and Eugene Police, the Methadone Program, Shelter Care, and many other social services that are involved in that coalition. They have some smaller work groups too within those groups that also involve community members or people who've been personally impacted by some of these diseases, and we think that that voice is really important when we're talking about our community interventions. We also work with youth too. The Planned Parenthood Rev group has been really involved in helping with those coalitions as well. The other piece I want to note too is we talk about, or Dr. Gail Boland, who is the CDC director for the STD prevention division, has talked about congenital syphilis increases in the United States being a symptom of the failure of public health infrastructure, that there is no reason why we should have congenital syphilis in the United States. If we had a successful or an adequate public health infrastructure, that wouldn't happen. People would be tested long before a pregnant woman is giving birth who has not been tested or treated for syphilis. I want to note that the state has made an investment in the public health infrastructure with the last 2 bienniums with public health modernization. So that is the goal, I believe, of modernization, is to bring our system up to 21st century standards. So we are working with the funding that's been made available by modernization to improve our communicable disease investigation, outreach, and response locally. We're building on the lessons that we learned in the last round. We have talked about the AFIX program and expanding vaccination through working with provider and clinical partners. So we are working with many of those same providers and some new clinical providers and how to do that same kind of approach, a quality improvement approach with STD testing and treatment. So that is, that's that is, I think, going to be a really great way to kind of knit the whole system together in terms of expanding the work that's been started in the STI Prevention Coalition and building out to a larger provider community. So we're also going to be adding an infectious disease epidemiologist soon. That has definitely been a gap in our CD services. We haven't had the ability to dig deep into the data that Dr. Pat mentioned to really find out what the risk factors are or if there are particular groups we should be targeting. We have a large sense of that, but there's a lot more we can do with the data that we collect, and also just with doing better interviewing and talking with more of the communities impacted to identify better interventions for these groups and the areas of the county that we need to increase services to. So that will be informing our efforts too going forward. I want to give an example of the surveillance that we'd like to do more of in the future is really this focus on youth to 1 in 2 sexually active youth nationally under the age of 25 will get an STD. That's half of all people under the age of 25. That's an extraordinary number. And we know that prevention is most effective if provided early. The HPV vaccination, for example, is supposed to be administered before sexual activity starts and the exposure to HPV is possible. What we don't have, though, is a vaccine against poor behavior choices, right? And we could all use one of those. But we know that behavior is hard to change.
Get back to us when you get that.
We know that behavior is hard. When we say preventable, it makes it sound like, there's just a few little things we need to do and we could prevent this. But we know that behavior change is extremely difficult to change. And the way that you want to address behavior change on a community level is, we've talked about this before, is making the healthy choice the easy choice. Leaving individual behavior choices up to people every day is difficult, and people under stress and in very difficult environments don't necessarily make the best choices. Their systems are overtaxed for making those kinds of choices. So we need to do everything we can as a system and as a community to encourage those good behavior. So changing sexual behavior is hard, but it's something we also have to be able to talk about as a community in order to be able to make some good changes in our community and to normalize those kinds of discussions. So for the next biennium, for 2019, the one we're in, 2021, our goal is to expand field work and partner services. We are adding an additional disease intervention specialist, someone who will work in the field with our current DIS. We plan to enhance data collection using this syndemic approach we talked about to address risk factors, so also looking at homelessness and substance abuse, behavioral health. We're going to increase provider and clinical outreach to improve testing and treatment. This is also part of the work that Dr. Patton and I started with the Kresge initiative to build relationships across our clinical and provider communities so that we can address issues like STD in a more systematic, systems-level fashion and kind of get some more standardized messaging and awareness out into the community so that everyone is participating in that. And then finally, we want to develop communication strategies that address disparities in these diseases that will normalize testing and HPV vaccination and destigmatize behavior so that we can have conversations and that we can get people into testing and treatment and that they're not embarrassed and that they are able to seek services effectively. So with that, we have time now for questions, comments.
And Chair Sorensen, as we toss it back to you, I guess I would also add 2 things. First of all, I just think our public health staff is amazing, and I wanted to take a moment to acknowledge the fantastic work that not only has been happening the last 2 weeks related to measles, but happens every day. And I think oftentimes public health works in the background and the community doesn't really appreciate all that happens to keep them healthy and safe. And so I wanted to take a moment to just acknowledge not only Pat and Jocelyn, but all of the staff in public health who are really doing amazing things in the community. And the second thing is, as you sit as the Board of Health, you have asked that the semi-annual reports include the entire Department of Health and Human Services. So I just wanted to acknowledge for anyone who's watching on television that the full report is attached in the materials, and we do have updates from all of the other divisions. And so if you have any questions about any of that material, we're happy to answer those, as well as the topic that we lifted up today in terms of measles and sexually transmitted disease.
Well, thank you. And, you think about what role government plays in people's lives, and maybe you think about police services, or maybe you think about the roads we drive on, maybe you think about, the library, if you get to go to the library. But imagine what our society would look like without public health. I mean, it's a pretty essential service that government provides. So, the people that work in this field, they put their hearts and lives into it, and you're just the tip of the iceberg here of all the people that are involved. So we really appreciate the work. My question is, you touched on homelessness as part of a risk factor maybe for these diseases. And I'm told that the point-in-time count that HUD requires local governments to perform is off by a magnitude of 2.5 to 10 on any given year that the count occurs. So when, for example, ours point-in-time count was 2165. So I just wondered, is that accurate data that it's off by a factor of 2.5 to 10 times?
Wow, I think I'm answering this question.
Oh, okay.
I would say, as with many of those surveys, we don't know what we don't know. We've only counted the people we could find. Absolutely, we would say it's an undercount because those were the people on that particular day we were able to find. And we know that some people cycle through homelessness throughout the year. So I don't know exactly what the factor is to multiply that by, but certainly I would say that it's an undercount of our total homeless population.
But you don't know about the methodology that says it's between 2.5 and 10 times larger?
I'm not familiar with that. I can certainly get more information. That's a pretty wide range between
Yeah.
2.5 and 10.
Yeah, and the study I looked at was a 2001 study, so this is 2019, so that was a while back. So I don't know if the methodology has improved or not. Over that period of time.
I'm absolutely happy, Chair Sorensen, to talk with our staff who administer the point-in-time count and get you more details on that.
Okay. Other commissioners with comments, questions? Commissioner Farr?
Thank you. I'm interested to hear what that study was, the 2001 study, and see how it does compare to today's estimates. Dr. Warren, at the Public Health Advisory Committee meeting last night, you gave a great presentation on modernization and on STI. And the Public Health Committee had a number of questions surrounding STI. You talked about many of the things that Dr. Ludke stressed today, and it's a very curious committee. My representative, Diana Applegate, had a question regarding what I think we call is outreach into the community, standardized messaging. Her question was, how do people in the community know about the symptoms, the treatment, and the risk of STI? And the answer was, I'll not say, tell us the answer.
I don't know. No, I absolutely think that is an area that we need to improve. We need better community outreach around maybe sexual health in general, but certainly the scope of the problem with STIs in our community and where people can get help and what's available. Absolutely. I mean, and that would be, that's sort of, it's hard to say what a general community campaign would look like, and that is one of the goals of that STI Prevention Coalition, to start developing some of those materials, and the work of our modernization group that we're working on regionally. We're working with a health equity group as well to make sure that those communications and those messages and campaigns are culturally appropriate as well, and that we are reaching the groups that we really need to, but we've only just begun that work with this new modernization biennium, so we don't have really anything to show for that yet. But that is absolutely I think communication in general is a place where public health can always do better with our community.
And that is one of the pillars of modernization, is communication on a number of fronts. So in response to that, we have the statistics that 1 out of every 2 people under the age of 25 will contract STI. pretty alarming numbers. If 6 kids get off a bus, 3 of them are a time bomb ticking. So then the question once again goes back to how do we continue to improve our communication? And modernization is certainly, we're getting funds to help us with that, but really, I think that's something that we need to pay attention to, not just in this county. I asked you last night, how do we compare to other counties? And really, there are no statistics, no data on that. But the numbers are regarding the state of Oregon. Oregon is an outlier in the rate of contraction of diseases. And Dr. Lichty, you're kind of nodding at that. That was the discussion that we had last night. That's an accurate statement? Oregon is higher than other states?
Well, for a number of conditions, we are. I mean, even our rate of cancer is higher than, but if we're just talking about STIs, we have higher rates for several of them. So, for example, people typically don't think of hepatitis C as one of the sexually transmitted infections, but it is. The numbers are smaller. We're number 1 or 2 in the country for hepatitis C deaths in Oregon. I mean, that's not where you want to be in terms of a sexually transmitted infection that causes death in some people. So for select conditions, we are on the bad side of good.
And thank you for that confirmation. You know, once again, the discussion centered around how do we begin a more robust communication program that's going to reach people at a deep level. And I think back on my years at Tillamook High School. And in my sophomore year, we had health. It was a required subject, health. And about a third of the year was on sexually transmitted diseases. And boy, by the time that year was over, I had images and pictures and absolute, what I felt at the time was a pretty in-depth knowledge of the risk. And it is it certainly is a deterrent, but the education regarding what to look for and how to respond and how to prevent seemed to all happen when I was a sophomore in high school, and we're not doing that today. You know, I don't think that. I think we're because of conditions surrounding the school formula and the way curriculum is that was remodeled after Measure 5. We've kind of abandoned at the critical age when kids can really, when we can make a significant emotional impact on kids that really lasts for the rest of their life. And if 1 out of 25 are, 1 out of 2 are contracting, 50% of all kids are liable to contract before they turn 25, then it seems to me that if we begin an early education process and we continue with an early education process, I'll go back to the Public Health Advisory Committee once again last night. The discussion that went around the table was, well, how do we get to people? And they talked about, well, should we do it through the religious community? Should we do it through nonprofits, whatever it may be? And I guess that really is a question that is hanging out there. How can we, potentially through public health modernization, increase our outreach, increase communication to help prevent that 1 in 2 number? So once again, a wonderful presentation last night. You had a very engaged committee yesterday. Thank you.
Okay, any other commissioners? Commissioner Bozievich?
Sure, and it's tough not to have 100 things to ask you guys. As I wrote notes, that I could go on for a while, but I kind of wonder. I remember health class too. Probably we're similar age, but and a couple weeks ago, I attended every 15 minutes out at Elmira. And it's like, where's the every 15 minutes for STI? Because when we're talking about changing youth behavior, sometimes you have to be pretty dramatic to change that behavior. It's interesting, STIs are kind of an indicator for a lot of other issues. It's an intersection of, drug use, homelessness, some cultural attitudes around sexual behaviors. One of the things you guys did not talk about today, but you talked about in our meeting with the 2 state senators on public health modernization, was the difference by minority demographic in STI infections that is present in our community. But the one thing you didn't mention any of this is the relationship to that to human trafficking. And, when we talk about Oregon kind of jumping out nationally in STIs, one of the worst homeless problems in the country, where we're number 4 by, population per capita, one of the worst drug use issues in the country. I think we were number one for combined heroin and meth use in the country. And, we're part of the I-5 human trafficking corridor. And we have one of the worst funded public safety systems, so we have gangs that participate in this human trafficking and that culture around it. And so there's this huge number of problems around this that lead to our high rate of STIs. So we have to, start picking at some of that somewhere. And one of the things that really, somewhere along the line, we have to talk about the cultural issue of how people view women and sex for sale and some of those issues and how that differs by culture and demographic, and maybe changing that and trying to introduce some change to that in young youth, not just about, this is what can happen if you get an STI. This is why you should have respect for women. And not think of it as a victimless crime when you purchase sex. We don't talk about that much. Or it's a victimless crime when you view pornography. And how that's changed our culture. It's something we just kind of shy away from. And something I think we need to have a discussion of as a community. Because, really some of that comes down to just that kind of whole view of how this culture treats sex nowadays. And how people don't think about the victims and the other end of those things very much. And trying to change that culture in some way. And I don't know how we do that. But, that's really some of where we need to kind of attack this issue, is on that end of the spectrum. And not that I'm, the libertarian side of me is definitely, I don't want to be the culture police, but we have to, as leaders, this is kind of like the Choose Kindness campaign in some ways, speak about, respecting others and understanding the victims in the sex trade, the victims in the pornography trade, and where that leads. And then the ultimate, spread of STIs is just a symptom of that poison that infects our culture. So, but I want to jump to a completely different subject and just ask a little bit about Lyme disease in the area in Oregon, because when we talk about syphilis, Lyme is not a whole lot different in some ways, as far as a bacterium that is reacts to treatment pretty well, but if it doesn't, it can be a lifelong and horribly debilitating disease to carry for your life. How are we doing with some of those prevention? Because that's another disease that's slowly climbing in Oregon.
So, Commissioner Bosevich, I'm happy to speak to that at least a bit. So, we're fortunate in Oregon that we don't have a lot of Lyme disease. However, we don't have a great surveillance system for Lyme disease. 3 years ago, the National Park Service did a tick check up in the mountains, so the eastern part of our county and Jefferson, Deschutes County, and they sent us the data, and they found, I think it was about 40% of the ticks that they picked up, and they only had 20 ticks or so that had Lyme disease in the ticks. So it's here. We know it's in our state. Thankfully, we're not like Lyme, Connecticut, which is where Lyme gets its name, from the city of Lyme, Connecticut, where it's everywhere. So we're lucky in that regard. I think the biggest challenge we have right now, and I don't mean this as any disservice to people who have Lyme disease. One of my sisters got terrible Lyme disease and Lyme encephalitis, and she was out of work for 6 months. It's a terrible disease. But we just don't fully understand what to do with people who get the bad side of Lyme disease. If we pick it up early, if we get the clinical community and the broader community be thinking about, I had a tick bite, I better go see somebody and get tested, then we can treat people quickly and they're not going to get a chronic condition from Lyme. Once they've passed that window of opportunity, being treated early, you can get a chronic condition that can affect you for the rest of your life, and it can cause heart disease, arthritis, some really nasty things. So we don't know what to do from a scientific standpoint with people in that condition. There's kind of a fork in the road. There are people who believe that it's a chronic infection and you should be on chronic antibiotics for years. There are others who believe, and this is predominantly the opinion of the infectious disease doctor community, that chronic antibiotics cause far more problems than they produce benefits. You end up with resistant organisms, you end up killing all the good bacteria in your gut, and you get chronic diarrhea and other problems. It's a real challenge. So we just don't know what to do once someone has passed the opportunity to be treated early and cured. And there's a lot of smart people studying it, but we don't have a clear way forward.
Let's see, we are over on our time, commissioners, and I just want to get a check. Who has not spoken on this? You and Heather? Okay. So Commissioner Buck, then Commissioner Burney, and then we'll move on to our item 2B.
I just had a couple of questions. I want to thank Commissioner Farr for bringing up the issue in schools, as I was kind of going there myself. It's interesting because I read book stories to my daughter at night and before bed, and there's these fun Junie B stories that I'm always reading her, and the ones that we just read were about the nurse's office at the local school and playing around with Band-Aids and whatnot in the nurse's office. And we've gotten away from having an on-site nurse full-time in our schools where they could monitor some of these things. And it made me also think about the nurses that came and got their award here not long ago for all their work in the schools that they're doing. And I know that there's just not enough of them funded for our schools, which I think would be a great leaps and bounds to be able to track and catch some of these things when they're younger. My question was, do you see that, that effort where we now have a few more nurses being able to go out to some schools on a part-time basis? Do we see anything in the future where that might be something that we could expand? Do the nurses go to the mission? Are there places on site for the mission? We see, majority of our people that are chronically homeless go through there, and it seems like a logical site. You could be doing that. I just didn't know. And if there are nurses in our schools or going to these places, I'd be very interested to know what the statistics or data that they're bringing back from the school systems as a segment of that I think would be important data, especially if we're seeing, half of our young people getting infected at younger ages, and that being part of it. And I'm assuming that you are in good coordination with the university, and so that's most likely pretty solid. But from the different school systems, is that data coordinated with the public? Our public center where we're collecting data, can that be improved? Mm-hmm. What about that is happening? And then my last portion of that question, unrelated to some of the nursing questions, is do we have any demographics between rural communities versus metro center communities? We know that rural communities have less access to healthcare, and I wasn't sure if there is any statistics about any additional, or we're seeing any more percentage of cases in rural communities, or if that's just data we may not have.
Mm-hmm. Okay, I'll start and you jump in when. So as far as schools go, I think there's a couple different things with that. There's definitely nurses in the schools, and in terms of the clinical piece, so providing individual level services, I think that is really important. School-based health centers have been included in the Community Preventive Services Guide as I think the only effective way to address health disparities in communities. So it really does open up access to care for a wide range of people that are more comfortable with seeking care in their own communities. So that's kind of an aside, we can talk about that more another time. I do think that it would increase HPV vaccination. We've had a pilot that we did as part of our regional work last year with the AFIX work in Lincoln County, partnering with school-based health centers to improve HPV vaccination, and that was really effective. And I think that is something we'll be looking at here locally as well. That's important. The education piece is a little different than the clinical care. Oregon has some of the best comprehensive sex education laws on the books. I don't know in terms of implementation what that looks like from school district to school district. There's obviously a lot of latitude for schools and what they are actually implement, and I don't know that they're all necessarily implementing comprehensive sex education at an early age. So I do think that that could be a gap and something that I don't know if that's the purview of public health necessarily. We would absolutely be interested in supporting schools that are interested in doing that. There's been, in my opinion, and I'm not, it's been a while since I've looked at comprehensive sex ed, but there used to be more support, I think, at the state level for it, and some of that has been less over the years, so that may have something to do with the erosion of sex education in the schools. I'll let you speak to the mission. In terms of demographics and schools, and I'm sure you have something to say about that. In terms of rural and urban, yeah, we do have information about the location of some of cases where people reside. We had a cluster of HIV cases, for example, out near the coast. Was that 2017 or 2018? 16. So we do have information about that. A lot of that is part of our contact investigation and case investigation when we have pieces. I do think, though, that that's going to be a big piece where we can do better with better data surveillance and with an infectious disease epidemiologist to really help us dig in to some of those questions, and not just cases themselves, but also the risk factors. And if there are parts of the county that are having access issues, I think that is a big piece. And we could improve then both testing and treatment outreach to those areas of the county.
So Commissioner Buck, I would just add, and briefly so, that I think you hit on two big opportunities. I think that there are real opportunities with the school systems. Our interactions are probably not as good as they could be, and the school nurse issue, and some years ago when we started to see our immunization rates drop, you could put a chart of decrease in school-based nursing and increasing immunization exemptions, and they would parallel each other. And you can't help but think that there's an opportunity there where someone is in school for 7 hours a day, there's an opportunity for prevention. And, I think it would be easy to say, let's have the schools do more. I mean, they're already struggling trying to educate in reading, writing, and arithmetic, but it's an opportunity. And the same, I think, goes with the Eugene mission. 500 people are there every night. And we have had a long-standing tuberculosis program with them. They had a TB outbreak in 2002. And we've been helping them not have another one for 17 years, and they haven't had one. They have these special lights that go up into the ductwork that can kill tuberculosis. They're ultraviolet lights, and they only last about 6 months, so public health goes and assesses them and makes sure they're still producing this UV light to kill the aerosol organism. But beyond TB, we don't do as much as we could with them. So I think that's a big opportunity. And then the rural and urban, I think Jocelyn hit on, a key example. When the HIV cluster we had in the Mapleton, Florence area, we had 5 HIV cases in 5 weeks. And we just told you we average 1 per month, so 12 a year. We had 5 in 5 weeks. Now, that's an alarm bell. So we were responsive, but that was reactive. We're not as proactive as we would like to be. We don't have a big enough footprint in the rural areas, and that's clearly an area that's an opportunity for us to look at more deeply.
Okay, Commissioner Burney.
First, I want to thank Dr. Ledke for framing this with the poem by W.S. Merwin. It's profound, I think, and it forms a context for. So my only comments are this. First of all, your work is tremendous. I mean, thank you. As someone who wouldn't be here without school nurses back when I was in elementary school, I appreciate to my bones some of what you're talking about. As I'm looking at this, I see discussion of a service infrastructure, and there's always more we could do if we had more resources. Education or campaigns or some ways to get people to be able to have that infrastructure as accessible as possible to people with the needs. And then what is interesting to me is motivating then people, from children to elderly, to be motivated to take advantage of that, right? And which gets to all those issues of how do people feel a sense of meaning in their life and purpose and hope and belongingness and comfort and all those things which will motivate them to access and take care of themselves. It's so huge when the compassionate libertarian on my left was discussing those huge areas. I mean, really, I was feeling overwhelmed just listening, and I understand that the point of intersection for all of those things that we're discussing now is not just health, but on those few areas that we're talking about, where there are measures, so there's some basis to make some statements and develop some programs. I'm wondering if it would be possible, because I hear us talking about education quite a bit. I'm wondering I believe that every district in Lane County is doing what they can, as best they can, as they are resourced. But I'm wondering if it wouldn't be possible, and I don't know how to do this, to ask each district, from the nursing clinical and also from the education, comprehensive sex education, what they are doing, what they would like to do for their students, and what they would need to do what they would like to do as it relates to the discussion that we're having. Because I think that would provide an interesting delta that we can actually describe and look at and partner and get closer to them, as Dr. Lutke, you indicated would be a good thing. But beyond that, I just thank you very much. I find this fascinating. When there's an opportunity for what it's worth, I don't know if it's being measured, but I would love to know, another indice or whatever, index of health, which relates to the number of young people that are now getting diabetes. And how that relates to nutrition and how that also feeds into the discussion that we're having. But I guess we could look at a number of things. But thank you so much. You have my absolute respect.
Chair Sorensen.
Go ahead.
And Commissioner Bernie, I would just add, I appreciate the conversation about the school piece, and we absolutely will do that outreach and connection. I think this is a particularly good time because of the planning to implement the Student Success Act. Each of the districts are really doing a lot of work with their communities about what are the most important needs and how to address those. So my guess is that they're talking about these issues and we can gather that.
Well, thank you so much for this item, and I think we should move on to the discussion, item 2B, discussion Oregon Health Authority Triennial Review of the Lane County Public Health Division. With us to discuss this, Karen Gaffney, Director of the Lane County Department of Health and Human Services, and Public Health Administrator, Dr. Jocelyn Warren, Lane County Public Health Manager, and Dana Drum, I hope I pronounced your name right.
You did.
Dana
Thank you.
Drum, very good, from OHA Public Health. And we set this up to be a 20-minute item, primarily your 15-minute presentation, so welcome.
Thank you, and Chair Sorensen, I appreciate you doing the introduction, so I won't take time to do that, and I want to thank Dana for coming down from the Health Authority to share with you basically the findings that the Health Authority had the last time they did their very lengthy triennial review of our services. So I'm going to turn it over to Dana.
Great, thank you, Chair Sorensen, Vice Chair Buck, Commissioners, it's good to see you. Thank you for having me here today. It's always a pleasure to come out and share the really positive results of the triennial review, and I also like to take this opportunity to kind of just review your roles and responsibilities as the Board of Health, and which clearly you all are well versed in and very engaged in terms of public health. And then talk a little bit about the review and what I saw as some of the highlights. As the Board of Health, you are really responsible for collaborating with Karen Gaffney and Jocelyn Warren and in their roles and to develop public health policies and goals. And over the years, Lane County has been very much a leader in that area, and really often setting the stage for work that can happen statewide because of your willingness to step forward. You also have a responsibility to be engaged in kind of the strategic thinking and work related to public health in your community, and you demonstrate that regularly. And then, of course, the local public health authority has a primary function of administering and enforcing public health laws of the state as well as locally. So, and you've done some really great work in that area. These are just some examples of kind of those governance functions that relate to things like isolation and quarantine, communicable disease, which you all have just spent almost an hour talking about, and then immunizations, licensing of facilities, regulation of public water systems. And all of these, we at the Health Authority are really work with a number of our local public health authorities around. These are the governance functions. These are part of the things that sit in why portions of public health sit within local government. So the next slide I'll go to is that we also know that you were part of the Public Health Modernization Assessment, which occurred in 2016, and probably will occur again in some fashion in the next few years, so we can see where we are and the progress that's been made. You've been very engaged in sort of how Lane County is modernizing, and as I was preparing for this presentation and thinking about Lane County public health, the things that came to mind for me were infrastructure and modern. And I don't want to suggest that they have all of the resources they need to do that work, because I know that's not the case. But this local public health authority does really good work around leveraging its funding and looking at putting systems and infrastructure in place to support really solid public health work. So the triennial review is based on two primary agreements we have with you. The first is the Intergovernmental Agreement for Public Health Services, which is the way we send funding from the state and federal governments to local public health authorities to help support that work. And then the second is the Environmental Health Intergovernmental Agreement, which is a little bit of a different agreement. It actually operates in the reverse, where you set fees for facility licenses, collect those fees, and then a portion of that gets remitted to the state, and that was set up in statute years ago. And then that supports kind of oversight of an overall state program to ensure consistency across jurisdictions, which when that was set up was a concern some decades ago. So the triennial review is based on those two agreements, and we really are looking to ensure compliance with state and federal regulations. We looked at 18 different areas. We were on site probably almost every day in April of 2019 because of all the different programs. And we really treat this as an opportunity to identify strengths and areas for improvement. We need our local partners to do public health in the state. And so we really aren't seeking to make this an audit or a gotcha experience. We really want it to be a partnership. And I've worked hard on that over the last few years. So as I look at areas of strength, again, I sort of do it through the lens of systems, infrastructure, and modern, and the commitment to build infrastructure, work across programs, and see and act on the connections across program areas, and then using data to drive the work and to make decisions. And you saw some great examples of that earlier. So I want to congratulate Lane County because you are nationally accredited by the Public Health Accreditation Board, and that is a significant milestone to reach, and appreciate the efforts that go into that and to demonstrate kind of that core infrastructure and in the work related to public health. Some examples kind of from a leadership perspective of some of that infrastructure is the focus on health equity and trauma-informed work, and that's supported within the organization with some employee committees that work across programs. Also, the CCO partnership, internal collaboration, things that happen between the communicable disease and environmental health programs. They're very much integrated when they're working on an outbreak. And then work that's occurred between the county council and other areas that require enforcement of public health laws and trying to standardize that and be consistent across programs. And these are areas that are just very forward thinking that we don't necessarily see a lot of other local partners doing. And so it's a really different kind of mindset that helps to move the system forward and as a model for the rest of the state. In terms of specific program areas, your maternal and child health programs have a bilingual nurse home visiting, or bilingual nurse providing home visiting services. Again, that gets at some of the access questions that you were talking about earlier. There's an emphasis on continuous quality improvement, which our maternal and child health programs consider a best practice, but it's not sort of a funding requirement, but it's a great example of that forward thinking and leadership. Your Nurse Family Partnership Program clearly meets a significant community need. Almost 600 clients have received services to improve overall pregnancy outcomes since the program started. And again, data is really essential to driving improvement. I'm a former resident of Lane County, and both my children were born here, so I remember the early iterations of that program, some of those programs. WIC, really some great innovative work here, again, about making the connections and improving access. So there's a weekly baby check-in drop-in clinic. So if moms have a concern, they know they can show up, get assistance if they're having trouble with breastfeeding or they need to do a weight check, that kind of thing. There's a weekly food distribution at the WIC clinic through a partnership with Food for Lane County. And then also at the WIC clinic sites, there's dental screening and fluoride varnish, and that's through a partnership with the CCO. But again, it's seeing those connections, bringing various program areas together that could otherwise be siloed to really serve residents and clients where they are. A lot of work has been done and continues to be done around reproductive health services, which are also connected to those sexually transmitted infection services that were talked about, the need for gender-affirming care and how that has transformed the work of the community health centers of Lane County, and also with other partners in ensuring culturally appropriate care. And again, using a community needs survey and interviews to inform and kind of lift up those needs. A lot has already been shared around communicable disease, but just to give you a sense of where you sit within the state and the volume of the work. During the review period, there were almost 2,300 CD cases reported, which represents 10% of the state volume. So a significant portion, and then 127 outbreaks, which represents about 16% of the total outbreaks in the state. And so that is a significant volume of work that's labor intensive, and you have staff that are consistently doing high quality work in that area. And how the work is divvied up is so that staff can work at the top of their license and the right people are doing the right work streams to maximize all of that. HIV prevention, there are a number of targeted outreach efforts, and you talked eloquently about the need for communications, and the role of social media in HIV prevention and STI prevention has become increasingly important and an important practice for public health to be adopting, and you're doing that. You're also approaching the work thinking about comprehensive harm reduction services and how do you bring all of those things together in one place so that it's a one-stop shop to get all those needs met. I won't spend much time on sexually transmitted diseases, but one thing I would like to call out is the Just Checking Clinic, which is a low-cost walk-in clinic where folks can come in. You know, there's a big emphasis on know your status in terms of HIV, but also other sexually transmitted infections. And this is a way that you create an access point for people to get the information they need about their health. And then a lot of good policies and infrastructure in place that support all of that work. In terms of TB, and Dr. Luckey was talking about that a little bit at the Mission, this is a high incidence county compared to other counties in Oregon for TB. And because of that, you have staff that are highly knowledgeable. They provide our staff important feedback for continuous quality improvement, and really are diligent at making sure that the needs of patients are met while also balancing the needs for public safety, which with TB cases can be a pretty tricky balance at times, and is also a significantly labor-intensive area of work. Immunizations, again, that's been a significant part of your immunization work. But just to highlight, again, the infrastructure and systems, the department has identified a way to make sure that vaccine is being that they're being good stewards of vaccine, they're captains within each of the clinics, and so, and then work with other delegate agencies in the community to make sure there's good access to vaccine and that the vaccine is being preserved for those who need it. And then in terms of public health emergency preparedness, you've had a lot of experience with this. You've had some outbreaks and things that you've needed to leverage and exercise that system. You have a lot of valuable community partnerships there and a collaborative approach to that work. So that not only can the county improve and be equipped for when there needs to be a response, but your partners also have that, that ability as well. In terms of some of the regulatory work, you supervise 282 public water systems. We at the Oregon Health Authority regulate sort of those larger systems, and then there are these sort of mid-size and smaller systems, and counties can opt to take care of those systems, to supervise those. And I think it's always important just to let county leadership know what the volume of that is, because that's ensuring that a large number of people in your community have safe drinking water. In terms of food pool, lodging, health, and safety, I know there have been some changes in leadership there, but that work continues to go well, with staff demonstrating effective relationships with the people in the community that they're working with, and inspection rates for all of those programs were in compliance. Tobacco prevention is in one of those areas where you have really stepped forward and been a leader in the state and helped create some of that critical mass to help drive more statewide policy. So support for tobacco retailer licensing, increasing minimum age of sales in unincorporated areas and municipal jurisdictions. All of that has, those were conversations and work you were doing before it became a full statewide conversation. And part of your work in that area has laid the groundwork for that further statewide work. So in terms of areas for improvement, I just want to say this is an excellent review, and so there were not many compliance findings, and almost all have been resolved. For communicable disease, there were a couple of things around just making sure there's complete data on investigations, but it was mainly some minor data entry improvements that were needed, and those have been resolved. Making sure that all cases are interviewed that require an interview within 4 days. That, I think, you are all, with the volume that you deal with at times, you have to triage and prioritize, and so certainly we want you to move towards that goal, but my guess is that is the department's goal, and that at times there's just a limited capacity. And then for immunizations, apparently we had an outstanding invoice that got paid. I don't know what happened there. But anyway, it's all been taken care of. And then sometimes I get questions about this other piece. So the local public health authorities are supposed to monitor the administration of hepatitis V vaccine before a newborn leaves the hospital. And so one of your hospitals, the Peace Harbor Medical Center, that rate dropped below 80%. I think it was like in the low 60s. And so there's a requirement to do some outreach to the hospital and figure out what support they might need to get their systems up to speed to at least make sure that that vaccine is offered. Certainly new moms can decline it. And then sometimes we find that there's been a changeover in staffing or something changed within the hospital system, which explains it, and then it gets fixed. All that's been resolved. We're still working with you around the tobacco prevention and education program. There's some past due indoor clean air act complaints and potential violations that are still in the data system that haven't been resolved, but we're working with you on that, and have extended the date to resolve by the end of December, partly because there's some information and support you need from us that we haven't provided completely yet. And then one WIC finding, which has until the end of this month to be completed, and it has to do with kind of the identification of the risk level when there's a change in that for moms seeking who are in those services. So you are well versed in the work you've been doing around modernization, and again, supporting systems and infrastructure, so I won't go into that. I'll just stop and see what questions you might have.
Okay, well, thank you very much. We appreciate your review and also the update from the triennial review. Commissioners, do you have any questions or comments to Commissioner Farr?
Thank you. Wow, that's all good news. A late bill. Who's responsible for this? It seems to me that would be kind of way down the list of issues that you have with.
Not to the program, that's why they call it out, but all your other bills got paid, so I'm assuming something fell through the cracks. It's all good.
I have a check in my pocket if you need to bring that one up. One thing that you touched on is our national accreditation. And you kind of brushed by it. You said it's pretty outstanding that we have received national accreditation. Back in June, I believe it was, that we received the initial accreditation. Yes. And at that point in time, I believe there were only 11 health agencies nationwide that had received it.
I know, we may be up to 13 now. I'm not positive for 13. Oregon, but it's almost a third of the local public health authorities in Oregon are accredited, and several of the others are still seeking that in the process. And
having witnessed that kind of from the sidelines, I know that was a great effort to get us up to that point, all of which was done. I think it was finalized right around April, which is when you said you were in the buildings just about every single day. Well, I want to thank you for giving us a good report and what seems to be pretty good news, particularly on the tail of the discussion we had on SDIs and the focus that we are placing on communication and making certain that we do address some of the areas that really Oregon in general is falling behind on. But when I was waiting for the hammer to drop, you went through slide after slide after slide after slide of strength. Okay, here it comes. A late bill. Oh my gosh. And then just to confirm, you did say that the two slides of areas of concern or have been predominantly addressed. Did I hear that right?
Yes, everything's been resolved except for the one WIC piece and the tobacco piece, and we're actively working with Jocelyn and her staff on those, and I'm confident those will be resolved.
And there was a surrounding Peace Harbor, the 80%, what was that?
I think that one's already been resolved.
Resolved already.
And in fact, and I don't know if, Pat, you want to speak more to this, but we've launched actually a perinatal Hep B project with our local hospitals in order to improve those rates across the, here, you can sit here. I'll let him talk.
Well, all I wanted to say is that this is a really important program. So if I got hepatitis B, I would have a 5% chance of getting chronic active hepatitis for the rest of my life, 5%. If an infant gets it, 50 to 60% of them have chronic hepatitis B for the rest of their life. So their immune system isn't mature enough. They don't have antibodies that passed from mom through the placenta for protection. If they get chronic hep B from mom, half of those kids are going to have chronic hepatitis for the rest of their life and probably need a liver transplant later in life. So getting this vaccine, it's a 3-dose vaccine, but getting it to the kid saves us a $500,000 liver transplant. It's a really, really important program.
Thank you, Dr. Lidke, and thanks for that confirmation that we did satisfy the deficiency there. Just generally speaking, I've been around the health department now for quite some time and watching the way your professionals work, and especially, I'm going to point out Dr. Warren. I've observed the way you communicate to not just staff, but to the Public Health Advisory Committee and other people who are involved in helping make policy, and it really is just a delight to watch. Thank you for confirmation of what I thought was going to be a pretty good report, but thank you very much for bringing us the good news on this day. Thanks.
Yes, thank you.
Okay, any other commissioners want to make any comments or ask any questions? Okay, I'll ask one or two. One is, can you give us any perspective on the general topic of civil penalties for people not being properly immunized, if there's a state or local requirement that they're immunized? I guess you mentioned at one point in your presentation about maybe a woman having a baby in Florence and she's offered a immunization for her baby and she can decline that immunization. So I'm not talking about voluntary immunizations. I'm talking about things that are required. Are there such things in our other public health authorities using a civil penalty because people may respond? We use civil penalties in the traffic enforcement arena, and it does have some effect on behavior. So I'm just curious whether.
Right. I'm not aware of other jurisdictions that have looked at utilizing civil penalties for not getting required immunizations. And I don't know, I mean, I think that would be an interesting conversation for you to have with your county council about
whether it's even allowed.
Right, what the authority would be to do that.
Okay. And then my other question was, public health is one of the greatest returns on investment in terms of we spend a little bit of money, and Dr. Ludke just mentioned an example of that where it costs very little for a small investment, and yet what we're getting in terms of return to society is really huge. And I'm wondering if there are areas in public health where a greater investment of either state or local money would bring about a quicker return on investment. And it's something that we as policymakers, as people involved in the budgeting process, if we could get our hands on the local money, or if we could make a better case to our legislators as to why more money should be appropriated in a particular area. Do you have any ideas for us on where the not low-hanging fruit, because I think we're doing all of that, but the maybe mid-hanging fruit is where we could put a greater investment and get a better return?
So I think So that's a really big question, and we certainly have some of those data that we can share back with you, and we actually worked on a report, sort of a review of the literature a few years ago in preparation for public health modernization, looking at some of those things. So I think where a lot of that, I don't know that there's been a broad comparison around if you invest here versus here, sort of where do you get the most bang for your buck. What I'm aware of is that the return on investment has been more program specific, that if you invest, say, in tobacco prevention, you get this much on your return on investment. But I'm not sure that you can compare those studies in vis-a-vis each other to sort of say this one is better than the other. I'm sure there is some out there, and we certainly can work to provide what we do have for you.
Well, just to the extent you have the ability to, contact the people on boards of health and around the state to give them sort of high-level return on investment data would be great. So if you could put me and all the other people that are on these boards of health on a big email and say, this is what we found, or this is what we have, that would be helpful.
Certainly.
Several of the commissioners here have either run for the legislature or have been elected to the legislature, or some both. And so, it'd be helpful in us advocating for public health dollars statewide. So.
Right, yes, thank
thanks
you.
very
Yes,
much.
I think the Trust for America's Health has done some really good work sort of looking at it overall, but in terms of if you're selecting within particular areas, I think it's been harder to sort of say do this over that, but we will get back to you if I can get back to you with some information.
Hey, thanks so much. And more comments from commissioners? Any? Okay, Joe?
If I may.
Yep.
I've reviewed multiple audits and program reviews. This is my first public health triennial review. I can't imagine a better review. Is that somewhere in the realm of correct?
Yes, although I have to say your colleagues in Deschutes County, I think, just had one of the first no compliance findings reviews. So, but that I think is the first one in the 5 years I've been doing it. No, this is a very good review.
Well, in the face of data, I will still refuse. Ours is bad.
They would feel I was remiss if I didn't mention that.
They're not here. My question is maybe an odd question, and I apologize for it. But you've mentioned a couple of times Lane County, for all the right reasons, has done some model programs. And you've said a thing I've heard in different applications before, which is the rest of this, for the rest of the state and nation to follow. So what is the responsibility of the Oregon Department of Health when a local county has done the model program to A, generate more resources for it, and B, to, disseminate it across the rest of the state? I'm just curious if that's okay.
Yeah, I think we certainly in the public health modernization work, we're actually moving this biennium to a learning collaborative model that will engage all of the local public health authorities, and our hope is that becomes a venue by which those kinds of best practices are shared, and as well as highlighting those successes and lessons learned in evaluation, as we have done over the last couple of biennia with public health modernization. I think the question you ask about resources is a very good one. I think the challenge is that we have very limited funding, and much of the funding that we pass through to you is federal funding, although we have seen in the last biennia, 2 biennia, some increase in state funding for public health. I think the funding question and who gets it is it's a challenging question that we struggle with the local public health administrators through the Conference of Local Health Officials, which is where we have a lot of funding conversations. Because if you reward those those jurisdictions that do work really well and have capacity with more funding, that means that others who have less capacity get less funding, and you create greater disparities between those higher capacity jurisdictions and lower capacity jurisdictions. And so I think that's a piece we struggle with. I think we also struggle with the sort of the balance between, you've got to have enough funding to have some basic capacity to be able to deliver the basic services, and yet when you're in a higher population county or in a jurisdiction where the burden is higher, how do you balance those two pieces? And as long as I've been in this role, or as long as I've been in public health in Oregon, I think those are the pieces that we struggle with, and wish that there were sufficient resources for everyone. I think your public health division has done an excellent job of leveraging resources and identifying the connections so that they can bring the work together and be more efficient and more scalable in how they do the work. And that's an important component, I think, of their work.
Okay, well, thank you so much. We appreciate you coming back to Lane County and giving us this update. And thanks so much to great folks in public health, Lane County Public Health.
Mr. Chair, if I may, one last sentence. Dr. Lutke, thank you for your participation in the Choose Kindness celebration this weekend. I understand the breakout group you had improving our community well-being was pretty well attended. So thank you for doing that.
Yeah, choose kindness, especially on the freeway back to Portland or Eugene. Okay, choose kindness. Okay, so next coming up was our 11 o'clock time certain. We have Mike Penwell and Will Dowdy, Matt Kohler. Oh, okay, yeah, we better do that. Thank you, Commissioner. At this time, we are going to adjourn our Board of Health and reconvene our Board of Commissioners. And we're moving to item 5A. And this is the discussion on the Eugene Town Square update. And Mr. Penwell, if you could just introduce, Mike Penwell is our Capital Projects Manager at Lane County. If you could just introduce the folks at the table. We set this up for a 15-minute presentation and a 15-minute period for the board to respond and ask questions, make comments. Go ahead.
Thank you, Chair Sorensen. To my right is Will Dowdy, the City of Eugene Urban Development Manager, and next to him is Matt Kohler, Principal Landscape Architect with Cameron McCarthy, Landscape Architecture and Planning. This item, the town square planning, is near and dear to my heart. 12 years ago or so, I was involved in a pretty comprehensive master planning around a city hall effort at my previous job with the City of Eugene. And one of the interesting results of that from our public involvement was the identification of the north half of the Butterfly lot as the preferred location for City Hall on a reclaimed northwest park block and tear the Butterfly lot down and so on. The county wasn't supportive of that at the time because of the desire to maintain that site for the future home of the courthouse. And then now roll forward, and in 2016, we did a coordinated development between the city and county. Again, I was on the city side of the table for that, and out of that came the decision to negotiate for the exchange of properties, the Butterfly lot for the former City Hall site. And in the process, I switched teams, and so I'm really happy to be able to introduce this item. The county has an investment in this out of the purchase and sale agreement, a monetary investment of up to $500,000 and up to $915,000 in kind donations. And so we've got a stake in it, and then we're all committed to the betterment of downtown and creating a heart in downtown that will help Eugene moving forward, and then the close association to the County Public Service Building and the current courthouse, and the connection of our Free Speech Plaza to the park block. So with that, I'll turn it over to Will to kick it off.
Thank you, Commissioners. Would you go to the next slide, please? I'm just going to give a little bit of introduction, and then Matt's going to talk about the work that he's done. It's great to be talking to you about this and sharing this project with you. I have talked with hundreds and hundreds of people about this project, and anytime the conversation begins with the fundamentals are the city of Eugene and Lane County had this vision, and so it's I'm constantly reminded about this idea of a shared vision between these two entities of coming together and figuring out what's the right fit for the center of our community. One of the other things that is a common part of my spiel with this project is to say what we're trying to do is we're trying to create a park that is at the center of our downtown neighborhood, and a park that is at the center of our city and our region. It's a gathering, it's the gathering place for people across the county, near and far. And so as I was thinking about talking to you today, I was reminded of the fact that involves you in two ways. Because as the county, this is the county seat. This is the place where people from all over come for any variety of reasons to do business with you. But also, this is the place, when we think of this as the downtown neighborhood park, when we talk about our neighborhoods, we're talking about the people who live there and the people who work there. And so this is both, this is that public space amenity for many people who work for you and perhaps live here as well, but who need this place as a place for the quality of life that they have as employees. So I'm thankful to be here. I'm thankful to present this to you, and I'm thankful that you as a county and our leadership as a city were able to come up with this concept that creates this project in the first place. Matt Kohler is with Cameron McCarthy. They've been the concept design team for us. They've put together a great team that has done some outstanding work going back into the spring. They also are going to be our landscape architects as we go forward with the project. So I'll turn it over to him to explain what it is that we've been doing, the designs and the process that we've gone through, and then I'll talk a little bit about the end about what our next steps are.
Good morning. First, let me say it's been a privilege to work on this project. I've spent the last 23 years of my career in the Quackenbush building where my office is, looking at the park blocks out the window. So I feel like to know that we've been able to be part of this process to date and will continue so is a great honor, not only for myself, but our entire team. So I'm going to kind of walk you through the concept design, explain some of the pieces and parts that are there, and walk you through a video that we have created that gives you a good feel for what the space will be like once it's constructed. And then I'll be focusing quite a bit on how we got there, because this is not a Matt Kohler or a Cameron McCarthy vision. This has really been a community vision, and we've just tried to be the tool to help kind of document it for our community moving forward. So to start with, and I'm not sure how many of you may have seen this before, but this is the kind of single concept design that we have landed on to move forward into the next phase of design. And this is the site plan that it encompasses what we are considering the town square. And really that is helped being set by the idea that the two park blocks plus what is known as the butterfly lot becoming a singular space that then ties into the Free Speech Plaza. So kind of recapturing what was the original kind of town square for our city and county. So this, the idea of helping to kind of set those edges was this notion of placing the city hall, the new Eugene City Hall, at the north end of the existing butterfly lot, and helping kind of set the edge for this square. As you move south from the City Hall, you land into what we have kind of been noting as the Farmers Market block. And this is really creating an expanded space for the Lane County Farmers Market. They currently kind of house the street edges and kind of really are on the border of that area. And what this design does is provides them a pavilion that you can see on this image that is considered, it's a covered pavilion, but open air. So it has either roll up or fold up doors that can then be closed down in inclement weather to allow for all season use. And the expansion of this block really allows for the farmers market to expand in the future. They have some goals, both immediate and long-term, to allow for expansion of what is a very successful farmers market in our community. As you move south from there, we get into the 2 park blocks, and we've been working as closely as we've been working with farmers market. We've been doing the same thing with Saturday market because it is another vital piece to our kind of downtown core. And on the park blocks to the south, that's where the Saturday market will continue to be housed. And so we've worked closely with them to make sure that their layout will work. And really noting kind of what we're terming as kind of jewels on each park. We have the City Hall, we have the Pavilion. On the Southwest Park block will be a new fountain feature that you'll see images of. The idea of it being more interactive and the ability for children to play. As we move to the East Park block, it's a new covered stage area that will allow for larger performances, better use by the Saturday market, and better use by the groups that are trying to use this area on a weekly basis for Tai Chi and yoga to have a place that they can do it more year-round. So those are kind of the jewels. Some of the big goals that were set through what we heard from the community was to try to make this place more accessible. There's a lot of levels as you move through our current park blocks area and a lot of obstacles, obviously, with like the butterfly lot itself. And so trying to open up clear sight lines for safety, but also allowing for accessible routes and clear open space to move through for those with mobility issues. And so you'll see as we move through the video kind of a reduction of the various levels that you see out there now. That includes removing the curbs on the street and bringing those streets up to grade to really create a unified town square space that can act independently by each block, but also as a whole. And finally, one of the big questions we always get right away is we are saving as many of the large existing trees as possible and have gone through multiple rounds of documenting their health and determining which ones are viable for long-term in our town square. So with that, I think I'll move through the video because I think it gives you a better close-up view. So, and when I presented this to City Council, I said I now go to my radio voice and kind of, talk you through the video. So we're entering from the southwest corner, so kind of from Kesey Square, and as you can see, maintaining the existing large conifer trees. And really, this is about, taking down that stage level that's there.
Sorry, I'm not sure what I just did. Trying to get some volume, and I knocked out the video. What's that? Oh, there it goes.
So as I noted, dropping in from this level. And as you can see, right now when you, yes, we have a little bit of sound in the video. So this idea of really getting the trees to a level where the kids can interact with them. Right now, they're in these really deep wells, and the stage areas really limit the ability to move into the block. As we move through the large trees, the idea of a new fountain feature that plays homage to the existing by its shape, but really it's at grade. And these fountains will allow for both spray, mist, or can just be a thin pool. It's something that's a little safer and more user-friendly for the many kids that try to climb into the existing one currently. We're looking at various options for custom seating and areas for families to gather. And this is kind of your first notion as we cross 8th Avenue of kind of narrowing up that street, it being at grade so that when larger events are occurring, people can move through this space. The idea of being able to hold festivals with the Farmers Market Pavilion on the left with its doors open, the City Hall in the background as we're moving toward it. And these tents represent how the farmers market could be set up. And we've been working very closely with Angela to determine the best layout for their long-term growth. We surprised quite a few of the farmers by the fact that they're in these images. But as you can see, it's a very, it's a much more open design on the farmer's market, allowing for kind of as much flexibility as possible. The Wells Fargo building is in the back here. What we're really trying to show here is that this space can be used in a variety of ways for our community. So this would be moving across Oak Street to the Southeast Park block and kind of the improved stage opportunity. So I hope that gives you a little bit of a better insight as to what the space will feel like as a user moving through it. But what's, I think, more important is how did we get there? And that is the process that has been the undertaking for the last 5+ months, and that is engaging the community and the stakeholders to understand their needs for this area. We started back in May with an event at World Pies, which we entitled the Imagination Lab. And it was really about, we didn't bring any designs, it was really about gathering input from stakeholders and community members. We had 300 to 400 people participate that evening. We had more than 1,000 surveys completed, which was a great stepping off point for us to take that information. We took that information, we met with stakeholders, including the farmers market, multiple occasions, and from there created 3 concept designs that we brought back to the community in July at a park. We called it the Block Party. And I believe this event has been noted as the largest public input gathering session in our community ever. We had between 500 and 650 people on the West Park Block, and more than 1,000 people did surveys. In fact, I think we had more than 400 that night at the event. I didn't know the total number of people that evening, but I knew that it was a success when at 9:30 I was still showing the designs to members of the community using the light on my cell phone because the park had gone dark. And we were supposed to have been done about an hour before. So following that, we took all of that input and created a single concept design. And that is what we presented to the community back on the East Park block this time in September at our September shindig. And we had 200 to 300 people attend and more than 650 survey responses. I'll just note that overall, just our public involvement piece, we met with more than 40 small groups and over 250 stakeholders in the downtown area. So that includes, obviously the farmers market, Saturday market, business owners. We had more than 2,600 survey responses throughout this process. We had more than 800 participants, some attending all 3 of the events. We had direct outreach. We had more than 75 individual events and spoke with more than 2,000 people. And we created a website and an Instagram site for this process, and we have noted more than 6,500 people that have been kind of connected through that. And so overall, through this 5-month public involvement process, we believe we have had contact with more than 10,000 people in our community on this project. So I think we feel very good about having that and hearing that, and that kind of takes us to, I think, our next slide, which is, okay, well, what did they say? And this is the kind of average of the final questions we asked based on the single concept. And it was an idea of checking back to make sure we had hit all the points that had been requested. And so we asked questions that really focused on, is the design safe and welcoming? Is it green and functional? Is it active? Is it memorable? And what we found was almost 75% of the people that responded either agreed or strongly agreed, and that 18% were neutral. And so what that meant is in this community, we only had 8% of people not agree with the final concept, which I will take as a win.
I'll say just 2 quick things to wrap up. Our plan, if everything goes well and everything runs smoothly, is that we could be doing a lot of design work in the next few months and heading towards an opportunity to do construction on the park blocks and the farmers market space during the next market off-season. So that would be the winter of 2020 and 2021. We are going to try quite hard to see if we can construct this without impacting the markets, and we're working very closely with them to figure out how to minimize whatever impacts would be. But it's not the best time of year to do construction typically, but we think it might be a possibility for us going forward. City Hall would take longer, but we expect that the finished work could be done for the park blocks and farmers market in 2021 in time to show the world some of the things that we're very proud of when the track and field championships are here. And City Hall would be completed probably the following year. And then I think there's one more slide. Where we are right now and what our immediate plans are is to move from concept into the next level of design. And that's coming up with more specific details about the design, the costs, the scheduling, and then what funds we have available. We know that with the funds that we have currently, we could build out some of this vision, and we've also seen that there are opportunities to add, whether they are private funds, state funds, federal funds, grants, and things like that, into this bucket. And so we're going to spend the next couple of months figuring out what is the right size project for us at this time, and then go forward from there. So thank you very much.
Well, thank you very much, and I'd like to open it up to commissioners for comments or questions. Commissioner Farr?
I think Commissioner Bozovich is waving.
Commissioner Bozovich?
Yeah. Thank you. The concept is really nice. I really appreciate the work you've done, and getting 8% disagreement out of this community on a public process, bravo. I don't think I've ever seen something with that kind of generalized approval or neutral ever. So great job on the public outreach and the work you guys did. And that's really a lesson to be learned for a lot of people is if you want to get the community to buy into something, you have to have them involved in the process and have them, walk through the design alternatives and really participate. And ultimately, when you get to an end product together, then everybody likes it. Two things, the engineer in me has to jump out, and if you've been with Cameron McCarthy that long, you were there when it was Cameron McCarthy Gilbert, and I worked with you guys when I was at Branch. The butterfly block and the elevation difference between the 8th and 7th is significant, yet your video showed very much a very flat area walking down to the City Hall. How are you going to manage to get a level area out of that? Is there going to be a retaining wall down Oak Street on the on this side or something, on both sides to try and get that level area, or how are you managing that access? I mean, it's great you're getting there, and I really appreciate that, but I'm just kind of scratching my head a little bit.
Yeah, that there is a general grade drop, but it's actually not as, I think it looks more extreme out there currently with the way the butterfly lot is. Based on some of our early calculations, I think we feel pretty confident that we'll be able to capture that in the City Hall area as we transition down to 7th, and that we're going to be dropping the street from kind of at grade with the Free Speech Plaza back to a more standard road at that block that will be the small block that is the City Hall. And so we looking at the existing grades, it looks like there's an opportunity to transition there and make it seem as seamless as possible.
So the second engineering question I have sort of is a traffic engineering issue. Oak Street is a major northbound thoroughfare. I mean, it's difficult to cross at lunch hour because it carries so much traffic, and particularly then in the afternoons, because it feeds I-105, the Washington Jefferson Bridge, and also the Ferry Street Bridge from south downtown and all that. Is there, with this idea of narrowing the streets up and bringing them to grade, it's going to be a pretty much of a obstruction. Is there thoughts on making Pearl Street two-way and moving traffic to Pearl Street and making Oak Street two-way, as we go through this process? Is there going to be a change in traffic patterns or to deal with that?
Well, I know that DKS Associates is doing a traffic study for the city on multiple streets currently. And I know that 8th Avenue is planned to go two-way. Currently, Oak is intended from at least the current planning to stay one-way. But our narrowing would not be of the two travel lanes. It's kind of removing the parking that's on that edge so that the park feels closer, so that people, right now, they leave kind of the stoplight by Wells Fargo, and because I drive that way home as well, you're looking at the light to go on to 7th, right? You're trying to jockey to get into that right lane, or the left, the left turn lane, not the right one, so that you can, get to the outer lane to, you're planning all the way to get up to the, to Coburg Road, right? So the idea here is that people look past the park. And so by kind of bringing it up to grade there, removing the parking on that piece, it will slow traffic visually. They'll see that, they will slow, but it's not meant to say, hey, you can't drive that way to go home. And so there'll still be the two lanes of traffic. We just hope that it'll go a little slower so that it's a little bit safer for the pedestrians in that area.
So this one's probably more for Mike and the administrator. Are there any changes planned to the Free Speech Plaza, maybe to remove some of the visual separation of the plaza from the rest of the park blocks? Because there are some kind of like islands we have there that provide that.
Yeah, currently there haven't been any discussions about making changes to the Free Speech Plaza other than a little bit of paving around the edges to integrate with the rest of the park blocks vision.
It just seems like as we go through this process, trying to open the visual connection between the plaza and the rest of the park blocks might be helpful.
Okay, Commissioner Farr.
Thank you. Not much other than praise for the process. We started this quite some time ago, really back when I was on the Eugene City Council. Things seemed to move slowly at first, and there was a land exchange that kind of impeded the progress. But to see the outline that you draw up there, and I look at a napkin sketch that was made in 2014, approximately. It looks pretty much the same, with the elements in different places, and more detail in exactly how do you involve people at the ground level. But, looking at the pavilion, to me, that is going to be one of the hearts of the entire downtown square, because that's going to draw people from all over the county and beyond. We look at people who come to town, for instance, for a football game in the fall. The draw to the downtown area is going to be just a tremendous impact, both economically and with the lasting impression that people leave our community with. They'll want to come back when there isn't a football game or when there isn't a graduation or whatever it may be that brought them to town. So the pavilion, when I first saw the pavilion at Olympia Farmers Market, and we look at what they're doing there in Olympia, and in not much larger space than we have here, and what you've drawn up really kind of is reminiscent of that at the south end of the Puget Sound, which is you go there on a market day, and I think there maybe are 180 market days a year there, something like that. Even with the roll-down doors that create more of a confined, not a confined, but a climate-controlled space where people do feel comfortable shopping there every day of the week, year-round. The whole thing is just really exciting. We had the, Mike, I'll say this right now, by the way, you look about 10 years younger than you looked a year ago. Has something changed in your life? Welcome to Lane County.
TMI.
We convened a group up in the Les Schwab room that we met a number of times regarding what are the basic concepts. And really, we were talking about, well, what I believe that the local restaurant owner was wondering what restaurants are we going to add there. And we went through a lot of iterations of what might be included. But really, what you're outlining and what we're moving forward with a timeline that looks very both exciting and aggressive is really you've captured really what everybody was thinking at the time, and I'm really impressed. I'm excited to look out through that window over the next 5 or 9 years and watch things happen. Thank you.
Okay, Commissioner?
I just want to say that the vision that you presented just feels so much more accessible and inclusive for the whole community. Right now, it does feel very choppy. And this could really just kind of open the whole center for the community. I also feel like this pavilion is going to be probably well used. I can just envision music and celebrations happening in a way in which, with the setting of the city hall, kind of looking out to the pavilion, a gathering space for government to be able to be out there with the public a little bit more and exchange ideas in a big open space where they can really see the future of Lane County and the city as it's growing from a town to a bigger city.
Okay, Joe?
Hey, I actually did this. I know I can hear bands playing and birds chirping. Oh, that was the sound on the video, wasn't it? Forgive the naivete of these questions because it looks wonderful. And I can't wait for this to occur and then the county to have a grand vision with the city of Springfield. And I don't expect any of these answers are in stone, but do we have a range of what this is going to cost?
We've got an idea for the park blocks and farmers market that if we built out the full vision, that we're talking about $25 million. And so, so we don't have that right now. And so that's where I said, well, we know that we can build something great there. And so as we narrow down on the cost, narrow down on the funding, we'll come up with a strategy of what do we do with the money that we have at hand.
Right. No, it makes sense. And is this predominantly a City of Eugene coordinated assembling all the money? And
yes.
Yeah. So I think strategically we have to do this before the World Games. And that's my only comment. So engineer, I really am not the one to use the term engineer, whether it's water engineer or traffic engineer or any kind of engineer, but reverse engineering, have you done that? And I'm sure you have, so that by the time the world is looking at Lane County and Eugene, this is a big piece of what they are looking at. Are we on schedule?
We're on track for that. And so we need to figure out, again, go into those details, and we're trying to bring a contractor on board to help us provide some guarantees in with our estimating and our assumptions. But we have a lot of confidence that we'll be done in the spring of 2021, well ahead of the World Games.
Got it. And then my last question is, I saw on the maps, the location of the Eugene City Hall, and I understand that the costs of that are not a part of what you just shared. This is probably a dumb question. Has the Eugene City Council actually decided that in fact is what's going to happen?
Yes. So they have told us to. I should be clear about what they've told us and what they haven't told us. But they've told us to design a city hall on that site. We still need to present costs. So there's more decisions that the city council needs to make. But we have the direction to move forward with that.
Right, and for this you have to assume. Okay.
Yep.
No, thank you very much. It's fascinating. It would be wonderful to see this materialize quickly. Thank you.
Okay, Mr. Mokrohysky wants to add a few things.
And I'll defer to you, Mr. Chair, if you had comments. I just wanted to get in the queue
Go for it.
So I just wanted to share, and I appreciate that both Mike and Mr. Penwell and Mr. Dowdy referenced this in their comments. But I think it's important to reflect, particularly for the new commissioners, that what you saw today, which are really an incredible vision and renderings and great planning and engagement work by the city and its partners, almost didn't happen. It almost wasn't possible. And so I think it is, and Commissioner Farr, you sort of referenced this, but the city had a process for City Hall moving forward, and it was really a difficult time when the county then sort of caught up on its courthouse planning and approached the city and said, can we pause and rethink what's in the greatest, the best interest of the community as a whole in terms of placemaking for future generations. That was a tough conversation to have, and I think it was really difficult for the city to hit the pause button at that time, but they did. They listened, and they've been a great partner in this process. But that was really a critical moment for the county in stepping forward and asking for the city to partner with us. And I think it's resulted in a wonderful partnership to date and this great vision that you see going forward. And so I just wanted to sort of call that to your attention again, that this was almost something that didn't happen. And I think it's a recognition that this is not only the county seat, but it is the center of the largest urban area in the entire county. And making sure that we have a place that is accessible and vibrant and positive for all of our residents to come to and celebrate our heritage and our culture and everything that makes this community great is really important, not just for the city of Eugene, but for the entire county. And you see that represented in the farmers market, that we're actually pulling in the agricultural industry from the unincorporated areas of the county into the vibrant urban center of the community. So really excited about that, and we thank the city. I want to just also note the former assistant city manager, who's now the interim city manager, Sarah Maderi, was really a key part of understanding the potential vision and helping in, bridge and create that partnership between the city and county at a critical time. And I think it's led to where we're at today.
Good. Well, thank you so much. We are really happy with this presentation, and thanks so much for the video, the hard work you put into it, and we're looking forward to continuing our good partnership. Thank you so much.
Thank you.
Okay, we're now ready to go back to the top of our agenda to look for any other comments, I guess, from county administration on announcements.
I did have a couple things, Mr. Chair, that I wanted to just mention. I think I covered, generally speaking, Mr. Martin's questions, but the fairground Conestoga Hut, there's neighborhood outreach, and then the work session on the 10th. We are recruiting for the what's being called the Strategic Initiatives Manager to sort of lead our housing and shelter efforts. That catalytic leadership position is currently under recruitment, and look forward to success there. Last week, I made some comments because we had some testimony about winter strategies, emergency shelter. I sent the board an email about a meeting that I had late last week with Terry McDonald at St. Vincent de Paul. I have subsequently had a meeting yesterday with the Eugene city manager and both of our staffs in the city and county to talk about winter strategies and the implementation of our shelter and housing plans. I will be prepared next Tuesday to provide a more in-depth overview for the board. We're coordinating those comments so that the city manager and I can both share a consistent message with our governing bodies and the public about where we're at and plans going forward. I have a meeting tomorrow morning with the city manager, and so there's a lot of work going into revising, refining, and expanding some of those efforts. So I'll have more for you next week on that front. And then finally, I want to just do Commissioner Buck mentioned the election, and I did have an update from Cheryl Betchart, our county clerk, that I want to just provide, that today is election day for eligible registered voters, and eligible means for elections that are actually happening in Lane County. Not every community within Lane County has an election, but for voters in the city of Eugene, city of Coburg, and Santa Clara Fire District, there are elections. Voter turnout as of this morning was 17.3%, with 21,324 ballots returned through yesterday. All ballots must be received at an official drop box location no later than 8 p.m. tonight. The list of official drop box locations is included with the ballot material and available online at lanecounty.or.gov/elections. Results will be released at 8 p.m. and updated at approximately 10 p.m. and when our staff concludes their work for the night. The election will be certified no later than the statutory deadline, which is Monday, November 25th, 2019. That's all I have, unless you have questions.
Okay, any questions for our administrator under item 8A, County Administration Announcements? Commissioner Farr.
Just regarding the SIM, we had two other FTEs that were approved, and that I understand that one of those positions has been filled by a pretty qualified individual from Alameda County.
Yes, yeah, that's our coordinated entry position.
Yeah. So moving forward very well on the recommendations. Thank you.
Okay, I don't see any county council announcements. And Mr. Mokrohysky, I know we have three executive sessions. Do you think we should try to do one of them ahead of lunch, or do you think we should wait?
I think at this point, I guess that's your call. If you want to try to squeeze one of them in, we could do that. Otherwise, we should have time this afternoon.
What's preference of the board? Does anybody have any preference
I think we have time in the afternoon
to do that? Okay. So why don't we then, with this kind of brief discussion, why don't we hold off on that? Is there anything that, Mr. Mokrohysky, you think we can do between now and noon to perhaps the commissioner announcements?
Yeah, and if you have any work session requests that you don't think would change in the afternoon, we could cover that.
Yeah, okay, so we'll have our first round of commissioner announcements at this time, item 13A. Are there any commissioner announcements? Okay, we'll go to item 13B, agenda team requests. Are there any requests for the agenda team? And last but not least, 13C, are there any work session requests? Okay.
Should do this more often.
You should do this more often. Okay, thank you for that guidance. So are we down then to our executive session, review of assignments, our 1:30 time certain, our 2:30 time certain, and our executive session? What's the approximate length of the executive session?
We have
Three items, all considered brief.
15 minutes. Well, it's actually two items. I mean, I'm viewing it as two items.
Okay.
15 minutes each, so I think it's
Okay.
about a 30-minute.
All right, so we'll have this as our current game plan. At 1:30, we'll begin our afternoon session. We'll do the county's equity work across departments. That'll be first at 1:30. At 2:30, we'll have the stormwater changes and funding shortfalls. Then we will have the executive sessions, and if there are any other work session requests or agenda team requests that result from that, we'll take that up and we'll do the executive session, and then we'll recess till 9 a.m. on Wednesday. Anything further? Okay, we're then in recess till 1:30.